And once again, thank you all for your wonderful presentations. One of the questions that came in earlier during your talk, Dr. Wachter, was how does an organization possibly make time to allocate the resources to investigate, to kind of figure out what's good and what's useful? And I had a question about that too, because you talked about the scribes, like how you're incorporating another person kind of into that relationship or into that interaction with the patient, and how does the organization decide like what's the best use of our limited resources that we have for patient care?
Well, I think it's no different than every other business decision that big organizations or any organization has to make. They weigh the cost and the perceived benefit of that versus alternative uses of the resources. What's different is the sort of amount of uncertainty around this particular use of resources. I mean, very little uncertainty as they model out the return on investment of building a new operating room or hiring a new neurosurgeon or opening a new site for primary care. There's always some uncertainty, but we sort of know what that looks like. It's been done 1 trillion times before. Here, will the technology work? What are the unanticipated consequences? Will patients accept it? What are some of the ethical implications? Will a regulator come in and kibosh it tomorrow? Will we get sued if something goes awry? All those things are, massive uncertainties. And if there's one investment that's certain and another investment that's uncertain, the certain one's going to win. In an environment like an academic health system, there's a little bit of counter pressure on the other side to be innovative and to build cutting edge knowledge, because part of the organization's DNA is about sort of learning new stuff. So that provides some impetus to say, well, the uncertainty is actually exciting and we should take some risks. So, a really complicated set of equations. We were talking at the table before about some other unique challenges that exist in healthcare that don't exist in other organizations. Every other organization, as they decide whether to implement AI or put in robots, it's a pretty straight linear shot. We are currently investing X amount in people to do this thing. And if we could replace them with AI or robots, it will allow us to do this thing better or cheaper or in a more customer-centric way. So it'll drive business. We were talking about the automated EKG readers. So the technology has been out for 25 years. And you might say, well, sort of an early bit of evidence about whether or not what will happen to automated radiology readers and path slides readers and skin dermatology substitutes. The challenge in healthcare that doesn't exist in most other organizations is, let's say I'm the University of Michigan and I feel I can replace a third of my electrophysiologists or cardiologists because they're spending time reading cardiograms, and it turns out the technology does it as well or better, just the same way your pharmacists are getting replaced in the factory you looked at. In a normal business, you'd say, well, that's a pretty expensive. Those folks make $350,000 a year. The technology is $50,000 a year, $100,000 a year. It's no brainer to replace them if I'm convinced the technology is good. In healthcare, you have this additional funkiness called health insurance. And the health insurance system, what that does is the cardiologists have a revenue stream that's independent of the healthcare system. So as long as the cardiologist can read a cardiogram and send a bill off to somebody, Aetna or Medicare or Blue Cross or whatever, and get paid for it, if I'm the University of Michigan, why do I care, if it's going to save me a little bit of, it's not going to saving me actually any money. So it really is an artifact of the payment system that who's going to have to buy the thing, probably the University of Michigan medicine, whose benefit, well, probably it's not us. It's, because the cardiologist is still getting paid through some other revenue stream. So that's why a lot of the motivation to do this is sort of artificially stymied by this sort of intermediary of the payment system. And if we actually do move eventually to a more prepayment, value-based payment system, where Michigan gets a certain amount of dollars to take care of every patient, risk-adjusted presumably, And now if we can replace the cardiologist, the radiologist, the pathologist with the technology that's cheaper and more reliable, and the benefit of that accrues to our bottom line, I'm much more motivated to do it than I am today, when to do it I'm going to piss off the cardiologist, and I'm actually not saving any money because the cardiologists are getting paid by Aetna. They're not getting paid by me. So that's an additional complexity that's going to have to be worked through.
Yeah, no, I agree. And I also just want to say, like, we're not advocating to get rid of the radiologists and the pathologists. We don't need them.
Well, nobody cares what we're advocating for. I mean, we always say that because I like radiologists and they're nice people, and I kind of today want them looking at my film. But at the end of the day, we sort of, our primary allegiance has to be to our patients. Yeah. And the cost of healthcare is bankrupting people and businesses and governments, and allowing, underinvestment in things that are really important. So at the end of the day, we can like radiologists all we want. If it turns out that the outcome of reading a film effectively and correctly can be done at 1/3 the cost by a technology, that's going to win. And the radiologist quite logically will fight that, because I would too if it were me. And they'll be back and forth, and the regulatory system will get involved, and there'll be ethical issues and all that. But, in some way, this is all, it's going to ultimately be fairly heartless. It doesn't really matter whether we like them or not. It really is going to be what is producing the best care at the lowest cost.
Well, and I think too, most of us are walking around with the EKG on our wrists. And so we're bringing that into the healthcare system in a disruptor in which you don't really have any control over. I'm going to switch gears a little bit. There was a question about COVID, and were there any studies using AI to advise patients on the risks and benefits of COVID vaccines, boosters, that maybe use their age, demographics, comorbidities that you are aware of?
So we're in a process, ironically, we've started a study developing a conversational agent, AI conversational agent directed at African Americans with comorbidities and COVID. And the idea behind this is to really help them manage information, right? There's a lot of misinformation. We just started the development of the application. We went through a series of interviews trying to find out, but I haven't, we haven't actually developed the application. I don't know if there's any, I've seen applications here at Michigan that looked at general populations, but not, and in particular what we're facing with is that there's this long history of distrust in the African American community, in the medical community. It's not uniform, but it is there. And so finding ways to design technology to help overcome that. It is what we're trying to do now.
I think too, I know that within our CTSA, which is the Michigan Institute for Clinical and Health Research, they've been doing a lot, not with AI, but just like getting into communities and helping them understand the benefits associated with the vaccine and the boosters, and making sure that they're meeting the communities, with the community's identity. So there's been a lot of work in the African American communities, our Hispanic populations, and having, I think there was a COVID clinic that was all Spanish speaking to allow people to get questions answered and to feel more comfortable. So
I would, every time I'm on the wards, I kind of observe that the most useful piece of technology that we've brought in is not our electronic health record. It's the virtual translators and interpreters. Translate. I mean, just not it's not Google's, it's actually a real person, but the fact that I can walk into a patient's room and the patient speaks Mandarin, and there's a screen there, and I press a button and a Mandarin speaking interpreter pops up on the screen, and I can now have a conversation. That process used to take 45 minutes. I'd have to call the interpreter department, and do they have that language? And so it's just breathtaking that, that you can solve, it's clear the technology really can solve a very important problem in a much less frictionful way. The idea that we will solve the misinformation problem through technologies is interesting. I mean, if what you need is a robot to tell you that vaccines are 95% effective and essentially zero risk, I'm not sure why it would be that didn't get through to you through other mechanisms, and whether the robot is sort of a solution looking for a problem, that there's something deeper there that we have to address.
No, it's often connecting people to sites that have reliable information.
Right.
And connecting them to people in their community who rely on reliable information, right? That's what we're actually trying to do. People, they go on Facebook, they find these crazy sites, they're off and running. And there are people at SI, for example, that are developing ways to assess the credibility of certain social media sites. And so a lot of times it's about directing people to more reliable information and helping them assess unreliable information. Yeah. Because it's going to be, linking them with someone in their community is going to have more influence than anything a robot or a bot can.
So it's a technology sort of linking them to people and information, as opposed to that somehow they trust the technology more than they trust the person.
Well, and somehow they wouldn't have come across that information. They wouldn't have come across those people.
That makes sense.
Yeah.
Well, I think this speaks to what Dr. Platt talked about with trust and making sure that people have a trust in the information that they're receiving, too. I don't know if you wanted to say anything about that.
We do need to have trust. I'll tell a quick story so last night we actually did a debrief with our research participants in the public deliberation. We had about 50 people on Zoom last night to sort of go over some of the results that we talked about today. And one of the comments was, but somebody started to tell the story about how they love the patient portal. It's great, but they, saw in their patient portal that some information about when they had received their COVID vaccine was wrong, and they had no recourse to fix it. And it was very upsetting, right? So it's like we need to find ways that our electronic health records and the reflection, sort of how the healthcare system is reflecting information back to people is accurate according to sort of the way that they have told their story, and that there's an opportunity to make that a dynamic sort of process of dialogue. So whether that's about getting the right information from the right source, or even just having the right information in the actual data source is an important, I think, component to what we're talking about.
What we discovered is that, for example, if you can connect African Americans in some cases with African American doctors who provide the same information that, let's say, a white doctor would provide, that there's more trust that when that information is coming from someone they believe is part of their community.
I think that's all. So the connection piece is important. Also, one of the things I've learned from having spent a fair amount of time with Google is there's a sensibility that is embedded in the way digital people think about the world that we do not have in healthcare, which is the fact that it is digital gives you the opportunity to learn from every click and everything that people are doing with your information. And so to constantly if you're putting information out there, is it working? Are people looking at it? How long do they look at something before they click? Google's doing that, Netflix is doing that. Every time we're on the site, they are learning from our behavior and they're iteratively making their tools better. We have no tradition of doing that in healthcare. And that, I think, will get at the issue of trust and information transfer. Some colleagues of mine at my place just did a study where they looked at the language that was in the patient portal that the doctors and others who were communicating with patients used, and what kind of language was associated with different kinds of responses and health behaviors on the part of patients. And it turns out that's knowable. You can sort of figure that out and then figure out, like, this sort of language didn't work in terms of communicating with people. And then maybe either prompts the clinician to use different language, or it translates the language into something that's more accessible. And I don't mean different languages necessarily, but different health literacy levels. Is so much embedded in the record, and yet we do none of this. So a lot of the future is, I think, truly understanding what works when it comes to communication and combating misinformation and changing health behavior. And some of that then, sort of technologically building in a learning system that iteratively makes it better.
So we had two questions that came in that are around mental health. The first one was for Dr. Platt about some mental health providers feel that treating mental health data differently adds to stigma around mental health disorders, and how do we balance public feedback and provider feedback? And then the second one is for Dr. Waljee, who said he was using AI to predict suicide risk and wanting to know if there's studies underway at the VA or elsewhere using risk factors to alert physicians about high-risk patients. So I'll let you two decide who wants to answer.
Sure, I'm happy to go first. I do want to put a disclaimer here. I am a gastroenterologist by training. I highly depend on my colleagues in the mental health domain to help me think through some of these challenging issues. In the VA specifically, it's not, and I don't believe currently that we have any prediction models looking for the risk factors. But given that mental health is such a predominant medical condition within the VA, I think the VA has done a fantastic job providing services and resources in those domains. And sometimes it's when you're challenged by what the active concern is in the health domain that you need to build up more services. In this particular case, because the VA already acknowledges that it's of high concern, those resources have already been developed around that. So it's really asking the question about where you think those models would be most useful. Sometimes if it's already built because there's a need for it, then it may not be necessarily something that needs to emerge. Was that the primary question? I think that was.
Well, are there models that you know of where physicians could be alerted to potential high-risk patients?
Yeah, not specifically that I know of. That's currently being developed in the VA.
I know that there's some genetic models that are now being developed, but I've not seen any of those being implemented.
Well, there's a ton of research going on in that area. I forgot the name of the researcher at Vanderbilt, but this is his main domain, to look at predictors of suicidality and then figure out what you do with it. Alert people. There are a number of companies that are launching that are predicting depression or diagnosing depression from the language that they see in your Facebook feed. And including, this gets wild, not just the language, but the speed with which you're entering data into the system is to some extent a predictor or a determinant of what your mood is in depression. So, who knows how much of this will turn out to be real and useful, but there's a lot of work going on in that area.
And sometimes one additional concern is that once you build a prediction model like that, you also need to make sure that the services are available. And if those are not available, it's like having a system to detect something, but you don't know how to treat it.
Otherwise, you just get alert fatigue then.
Yeah.
And then about adding mental health records, treating them differently if that adds to stigma. If you have any insight into that, and how do we balance public and provider feedback?
Yeah, it's a great question.
It's a big question. We could do a whole symposium on that one.
We could do, that's right, next year. I think a couple of things. So one is, part of the issue is, we have all kinds of data. Some of it's mental health data, but we can learn about people's health from social media data, from things that we don't even think about as being healthcare data. And so in some ways, the question is how do we treat different types of data differently, but more like how do we treat data in ways that are providing people with the care and safety that they need. And so if mental health data is going to help us with that, then that's probably the direction we should be going. The other thing in terms of, one of the things we've seen in particularly the qualitative work we've done both in biobanking and with the data sharing thing is that there tends to be sort of energetic, I'll call it, to the dialogues where it's sort of like, wait a minute, there's all this information out there. Like, I didn't know about this. This was a surprise. Like, you have information about my child, me. Like, what? There's this sort of like, oh my God, what's going on here kind of moment. And sometimes that's confronted with anger, and sometimes it's surprise, and sometimes it's happiness. But there's this sort of high, like, oh my God moment. And then as we begin to talk to people more about what can be done with the information, what can be done with it and how it's being used, and sort of the track record of healthcare institutions with using health information, that's often, then there people calm down, and you still have people that are like, that's still really interesting, and I still want to know. Others are like, okay, now I get it. It's okay. Go ahead. So, but there's a way in which whatever kind of data it is, having that sort of ability and space for people to go through those stages of information and knowledge about their health information, I think is an important piece moving forward.
I have a comment and then a question for Jody, which the comment is, as patients are having that, oh my God, I can't believe this is happening moment. Usually there's another moment often, which is, and do you know what's being done with your credit card data and your cell phone data and all that? And it's like, really? They can't believe it. But the question I had for you is, when you ask patients about the opt-out thing, I couldn't quite tell, am I opting out that you can use my data to produce algorithms, or am I opting out that algorithms are going to be used by, for example, my doctor in deciding how to treat me? Is it sort of the coming out of, is it the predicting, or is it the use of the predictions?
So in this case, the opt-out was in the context of, so the scenario was a patient receives cancer care at a hospital, they biopsy the tumor and send that to a commercial company. The opting out was not from the care or that sort of interaction of, with the commercial company in that respect, but then being able to opt out from future uses of that data and tumor sample. So that was in this particular study where opt-out was given as an option.
Interesting. Yeah, because you hear this periodically, like patients want to be able to consent that their doctor is using a predictive something in caring for them. I get it. I might even say that. On the other hand, my doctor uses up to date in predicting what's going to happen. The idea that you're using a resource that somehow uses an old predicted model to determine a prognosis that then determines a treatment. That's called medicine. It's hard to figure out how you would draw that line.
Yeah, I think opt-out in general, there are people that are like, okay, well, we'll just consent all the patients. And that's not quite right either. We can all check a box, but that doesn't sort of give people the autonomy that I think they're seeking or the level of control that they're seeking. So I think it's what can we do to give those kinds of options to patients where it's not opt-in. Opt-out is not really an option for some applications. Others there may be, but
before you go, I just want to say we are asking by the AV guys to make sure that we're putting the microphones up to our mouth. So just.
Actually, this is just a question to the panel group. We're holding AI to such a high standard, and what is the comparison? We're comparing it to imperfect human decision making, right? And I just wonder how we resolve that with the patients that we're talking to or the prediction models that we're developing when we're saying, hey, we're giving the benefit to the provider who has, and amongst multiple providers, there's a lot of variation in itself, and that's your gold standard. And then we're holding these AI prediction models to that standard. In some ways, when I talk to patients and other colleagues, I'm saying, well, this is just helping us do a little bit better than what we're doing right now. If it's better than a 50% option where we're not sure which pathway to go to, is it worth using some other supplemental decision support system?
So there is this idea that when you encode something, an automation, there's some, there's a difference between a human driver that makes a mistake and crash, let's say, than a autonomous vehicle that's programmed to crash in a certain way. One of those things we accept as a society, right, it was an accident, and the other ones we have a problem with, right? So once something becomes automated, then the idea of the error is no longer an error, it's no longer a mistake. People begin to see it as encoded. It is doing what it's supposed to do. And that's when you get a lot of people getting upset. This is why we have trouble with autonomous vehicles, right? Autonomous vehicles, they're really good, but they only have to be bad a little bit of time to cause a whole lot of problems, right? And I think sometimes we have an overconfidence in our ability to predict. If you give me a year worth of data, I can build you a highly predictive model and not know anything about what's going on. Very easy. Now, and that model can be very predictive with that data for that year. Now, how predictive it will be for the data for next year, well, that's a whole different ballgame, right? So oftentimes we get overconfidence. We get, our model can predict this, our model, but that's only with the data we have. And it's really not that hard to do. So I think we got to sort of scale back a little bit and realize that there's a lot of this overfitting of data that comes with too much confidence.
I think you just described the way we develop the flu vaccine every year.
Right.
Right? It's a predictive model as these are the strains we think are going to happen. And then usually in January, we're like, we were off. Sorry, you're going to get the flu this year. So, I hear your point on that.
And it is fascinating that humans are so uncomfortable with providing agency to the technology that, yeah, we will hold it to a higher standard and a higher bar. The idea that I need to get consent from a patient to use their data to make a prediction because the thing might be wrong is no more rational than I should get consent because the radiologist didn't get a good night's sleep last night, or the resident did the first reading as opposed to the attending, or a trillion things that probably degrade the quality of the prediction or the therapeutic approach. But the nanosecond that we say a technology is going to do this for you, it becomes, oh my God, sky is falling. We need to consent to that. It's a natural thing, but in doing it, we really have to be thoughtful about like, why is this so different? And that's partly why you're going to see augmented and sort of collaborative technology people models for a while, even when the technology is demonstrably better than the people or as good as the people, but much cheaper, because that will sort of feel like we're not crossing a line because people have always been helped by technologies of, forever. And there's another piece of it. This is a business piece. The idea, no one would for a second, I think, say to UCSF or to Michigan, you cannot use my data to have a quality improvement meeting, or analyze it and scrutinize it to improve my own personal care. And they probably wouldn't even balk at the idea that you're going to use my data to improve the care of people like me. But the minute that we form a business relationship with a company, and particularly if the company is called Google or Amazon, and the data is now going to this other entity that's going to do precisely the same thing that we would have done internally, they're just going to do it better and at scale because they're worth $1 trillion and they have a lot of smart people. It's like now, oh my God, you can't send my data out to do that. And some of that's rational because they worry about some of the other things those companies could do with data. But some of it is a very artificial line. And so, these are all just hard. We're going to have to work them through as a society.
One of the things that I've kind of been thinking of as you all have been talking today and through all your excellent presentations is not only just patient trust of AI, but also provider trust. And I've seen this time and time again where we don't really have a federal sort of infrastructure or support for the development of some guidelines that get broadly implemented. And so they tend to be very siloed. They tend to be very regional. Some places say, well, we don't really follow that guideline. We only follow this guideline. And what are your thoughts? I mean, is that what we're going to need in order to really, really embrace AI and really improve healthcare?
I would say if you're saying that we should consider the social context in which the AI is embedded in, I would say yes. Because we don't know enough to say we shouldn't. I mean, we know it's important. We don't know how important it is. We don't know when it's important, but we know it's important. And so for the time being, I think the answer is yes. Maybe in the future, maybe 20 years from now, we learn so much about AI that we can say, this is going to work anywhere in any place, push it out. Even then, I would argue, we push out technology to other parts of the world. Autonomous vehicles, if you drive in Ann Arbor, it's different than driving in Detroit, it's different than driving in New York, it's different than driving in Rio, it's different than driving in Delhi, and so this idea that this one technology fits out and we just, push it out. No, I think for a long time, we're going to have to be learning about how the context matters. And oftentimes the best people to learn that from are the people embedded in the context.
Yeah, another thing that I've learned from Dr. Platt in the past was does it come down to having sort of a nutritional-like label for every prediction model? And I don't know if we want to get to the point of, and this is an entirely different discussion around who is regulating that, but maybe there's an expiration date around that prediction model. Maybe the components of what you think is essential to buy in the trust on that nutritional label for that prediction model. And I don't want to steal your thunder, but this is your idea. Please, maybe.
Yeah, I mean, I think sort of there's a couple of things. So one is sort of understanding sort of where Dr. Wachter talked about this, where does the liability lie when a mistake does happen? So what are the recourses for that? And then I think the other thing that's probably, it would facilitate the adoption of AI is to be able to show what the benefits actually are. So if Google and Amazon can do this just as well as our healthcare provider, that's great, show me, right? If my provider is using a tool that's been used, or maybe is brand new, but they can say this is going to do better than I can. Let's have a conversation about it and arrive at a decision about your care using this tool sort of as an aid. Let's talk about that, and we'll show you how this has helped either you or people like you, or even sort of your community at large.
So let me address a question about that we're having a discussion now in school information. is, okay, let's suppose that's the case. You want to use my data. Should you pay me for using my data? If you're Google and you're going to use my data to produce some new AI that you're going to make a fortune on, how much of that should I get? If it's being driven by my data.
So we actually, I didn't show it in this presentation, but part of the dialogues included paying people as one of the options. And in general, people really just wanted to know. And, again, other people wanted the opportunity to opt out. Payment was sort of at the bottom of the list, in part because it seemed really complicated. They didn't understand it. And again, maybe to the trust question, but it was like, well, you'll pay me, but I'll end up paying more later down the line. Like,
Probably right.
Yeah.
Yeah, I mean, the regulatory environment is just incredibly complicated here. I mean, because you think of one kind of regulatory world that says that this machine that's purporting to diagnose path slides as well as a pathologist does what it says it's safe and effective. So, all right, that's what the FDA does for a living. They'll kind of figure that out. It's another to say this algorithm that predicts patient deterioration that better evolve over time as more data comes in, how that's going to get regulated at a federal level. It's just almost mind-boggling to figure out what that might look like. So it seems more likely that for that kind of thing, it's rather than the algorithm, each algorithm getting blessed, the entity that's doing the algorithm development gets blessed for a set of processes that have integrity and have been proven to work, and that they're building in the iterativeness, and they're going to look at its performance over time. And if we're blessing you to do that, we will bless you to do that today for sepsis and tomorrow for heart attacks. It's just hard to believe algorithm by algorithm that's workable. Maybe somebody will figure it out, but it seems daunting.
It's very challenging, and I think so. Being a pharmacist, and I do precision medicine, so pharmacogenomics is kind of my interest. And when I was first starting out, there was an AmpliChip, which is the first 2D6 genotype testing. And the reason we no longer know about the AmpliChip is it was FDA approved, and the company that developed the AmpliChip never wanted to update it. They never wanted to invest in that process, and so it became obsolete as the data about the genotyping came up, kept evolving. And then so now we have kind of these this clinical implementation consortium guidelines from CPIC for pharmacogenomics, and they've had a very interesting relationship with the FDA, where the FDA says, yes, you're doing great things, your rating scale is really great, and then they say, but this testing shouldn't happen. And so it's kind of this working with the government and figuring out exactly like you're saying, and having trust as a provider, but also in the patients, and how the data is being used.
Yeah. Another example of that is right now, nobody's regulating our labs per se. I mean, there's a certification and there's processes that are being upheld. And I wonder if that's a potential situation where those prediction algorithms could be set up, is that, again, we've got some best practices, and as long as we're abiding those best practices, we're the ones deploying it, similar to the regulations they have about who's calibrating the instrument in the lab to make sure that we're getting accurate lab information out.
I mean, if you think of the competencies of governments, and this one's particularly bad at this, but all governments, but the idea of keeping up with something that's this rapidly changing and iterative is just not anywhere on the list. And how do I know that? Because now they're trying to figure out how we should regulate, Facebook, from issues that were sort of semi-obvious 10 years ago, but that's how long it takes to say this is a real problem, and given the politics and everything else, now it's time to tackle it. And it's just hard to figure out what the regulatory environment can be if you're going to require that in real time they're regulating technologies without screwing it up and slowing it down irreparably.
So the EU is actually doing this. So it's very much doable. The European Union has regulations around AI about how you can use them, when you can use them, and what data you can use. So it's actually being done right now in the European Union. I'm not saying it's perfect, but it's definitely. But
are they scrutinizing individual AI products, or they're saying this is the environment and the set of processes that we need to bless?
Yes, they're much more than the later.
Yeah, that I can see.
Okay, thank you all. I think in the interest of time, I'm going to end our panel presentation, because I think We could probably have a whole symposium on the role of the federal government in regulating AI as well. I think, as we mentioned earlier, Precision Health at the University of Michigan really has quickly developed infrastructure and tools to help researchers in 3 key areas: discovery, treatment, and health. And so thank you all today. And then I think we're going to move on to the next part of our presentation. So thank you.